Welcome, everyone. We all know SGLT2 inhibitors are a game changer in heart failure. But what about in our oldest, most complicated patients? The ones who are usually excluded from the big clinical trials? Well, today we're going to dig into some really fascinating real-world data that looks at exactly that.
So just to frame this is an ADEF Journal Club presentation. Think of it as us breaking down a new paper, peer-to-peer, really looking at the evidence and figuring out what it could mean for how we think in the clinic.
Here's what we've got on tap. First, we'll talk about the clinical dilemma with patients over 80. Then, we'll jump into the real-world study that tries to answer some of our questions. We'll look at the big efficacy and safety findings, check out how these drugs did in frail patients, and then wrap up with the major takeaways and, of course, some really important caveats.
Okay, let's get right into it. Section 1. We really need to set the stage here with the clinical problem that, let's be honest, we all face in our daily practice.
This is the million-dollar question, right? The big RCTs gave us amazing data, but they tended to pick the healthier, less frail elderly folks. In the real world, we're seeing patients who are very frail, have poor nutrition, and super low body weight. For them, the evidence has been pretty thin, and it leaves us wondering, are we helping, or are we risking dehydration, infections, or even making their muscle loss worse?
So to try and fill that evidence gap, we're looking at this real-world retrospective study from Nakano and his colleagues over at Kokura Memorial Hospital in Japan. What they did was look back at their own patient data to see what's actually happening in this very challenging population.
So here's how they built their study group. They started with almost 3,000 patients who were hospitalized for heart failure. From there, they filtered it down to just those over 80 years old, which left them with about 1,500 patients. And these patients were split into two groups: the 233 who got an SGLT2 inhibitor, and the much larger group of over 1,300 who didn't.
Now, this is really important. Because this wasn't a randomized trial, you see some major differences between the groups right from the start. The patients who got SGLT2 inhibitors, they were a bit younger, they had better nutritional markers, and they were significantly less frail. This screams selection bias, right? It looks like clinicians were picking their better elderly patients for this therapy. You've got to keep that in the back of your mind as we go through the results.
All right, so with that huge piece of context, let's jump into the main event. What did the study actually find when it came to efficacy and safety?
And wow, this slide really tells the story. These are the Kaplan-Meier curves for the main outcomes over 1 year. The red line is the SGLT2 inhibitor group, and look at that. You see a clear, early separation from the blue line, which is the group that didn't get the drug. This shows a significantly lower rate of the composite outcome, all-cause death, and heart failure hospitalization. The difference is pretty stark.
So here's the bottom line. After they did all the statistical adjustments to account for those baseline differences we just talked about, the hazard ratio for the main composite outcome, that's all-cause death or HF hospitalization, was 0.66. That translates to a 34% relative risk reduction. Pretty impressive.
It gets even more dramatic when you look at all-cause death by itself. The adjusted hazard ratio here dropped to just 0.58. For a real-world group of elderly patients, that is a really powerful signal for a mortality benefit.
And to complete the picture, the risk for being re-hospitalized for heart failure was also cut significantly with an adjusted hazard ratio of 0.69. So no matter how you slice it, the efficacy signal here was strong and consistent across the board.
Of course, efficacy is just one side of the coin. What about all those safety concerns we have with this population? Well, take a look at these curves for things like stroke, UTIs, and dehydration. They are practically sitting right on top of each other. There's no separation at all, which tells you there was no significant difference in risk between the two groups.
Let me put that another way. The adverse events we tend to worry about most, stroke, UTIs, dehydration, they did not go up in the SGLT2 inhibitor group. So in this study, the treatment seemed to deliver the benefits without adding any extra safety risk.
Okay, now for what I think is one of the most interesting parts. Let's dig into the subgroups, because this is where the study really gets practical for those difficult decisions we have to make every day. This forest plot is just packed with insight. It breaks down the main outcome by all these different patient types. And just look, it didn't matter if patients were 90 years or older, had a high frailty score, or had a very low BMI, the benefit was still there. See how that little diamond, the hazard ratio, consistently lands on the left side? That means it favored the SGLT2 inhibitor group, even in these really high-risk patients.
All right, let's zoom out and put this all together. What are the big picture messages we can take away from this? And maybe even more importantly,
What are the critical caveats we absolutely have to remember?
The authors themselves really summed it up powerfully with this quote. They're basically saying that these drugs seem to work and be safe even in the exact patients that we as clinicians are often most hesitant to treat, the very frail, the poorly nourished, or those with very low body weight.
But, and this is a huge but, we have to be so careful about how we interpret this. The authors are very upfront about the study's weaknesses. It's from a single hospital. It's retrospective. As we saw, there was a definite selection bias, and there could be all sorts of other unmeasured things that affected the results. This is not the same level of evidence you get from a randomized controlled trial, not even close.
And that brings us to the most important point of all. This has been a journal club discussion meant to educate and inform our thinking. It is absolutely not a practice recommendation. This kind of real-world evidence is compelling, for sure. It might make us think twice before giving up on treating our elderly patients. But at the end of the day, individual clinical judgment for each specific patient is what matters most. So the question I'll leave you with is this. Does data like this change how you calculate that risk-benefit equation for your oldest patients with heart failure? Thanks for joining the discussion.